A very good evening to all of you. Uh, at the onset, special thanks to Dr. Saptrishi Bhattacharya and organizers for allowing me to be part of this academic feast. The objective for today's talk for me would be an introduction to artificial intelligence in healthcare, specifically the how is it different from artificial intelligence in any other field. Then application of artificial intelligence in diabetes care, and then specifically I'll like to talk about clinical decision support systems in diabetes care, where I would try to take you through a practical experience of ours in developing one of those systems in type 2 diabetes. So basically what an artificial intelligence is. Artificial intelligence is any technique which makes machine emulate what humans can do with their human intelligence. So it has different levels. It can start right from an expert system in which we have made some rules and we feed that into a software, and then given some few inputs, the machine would turn out those outputs as decided by experts before. So these are called expert systems. Then there can be that we have inputs, we have outputs defined, but we are do not have rules which connect both of them. So rule machine can make its own rules, and it can learn on that data, and then can devise its own rule to connect those inputs and outputs. And then there can be something called deep learning, in which we just give the machine data, the machine make its own rules, and machine also tells us that given this data, this can be the potential outcomes, or this can be the potential associations within the data that need to be looked into. Now, any artificial intelligence is as good as the data on which it is generated. So any artificial intelligence, we have to have some baseline data or rules on which their machine can iterate and then make that data. Now, if the quality of that data is not good, then the rules that AI is going to form are always going to be less than optimal. Now, why does artificial intelligence is lagging so behind in healthcare as compared to any other field of its application? Is because the data, by the nature of data that's there in healthcare. So our data is fragmented. A patient's data can be with lab, can be with pharmacy, can be with other doctors, but there is no uniform one single place where all data is collected. The data is unstructured. Doctors write their prescription in text form, which is very, very difficult to transform into a data form. And then our data has varied definitions, and the data is continuously evolving. For example, we continue using new drugs that keep on coming. So if the system has been made for the drugs which have been used till a certain point, then same data may not be usable in next 5 years or so, when we have access to new and new drugs. So the system has to be continuously evolving, and that data should come from the practice of diabetologist and endocrinologist. Now, in diabetes care, all the particular aspects of diabetes, be it diagnosing diabetes, be it predicting complications. Once somebody has diabetes, then whether somebody is likely to have complications or not. Then if those complications are there, then identifying those complications. So artificial intelligence is doing leaps and bounds into all these fields. Where artificial intelligence is still in infancy, or still we are still learning how to make artificial intelligence useful in this particular area, our clinical decision support system, when it actually comes to managing those people. Now we've diagnosed something, we have diagnosed diabetes, we have diagnosed type 1 diabetes. Now with help of technology, how do we make their treatment much more malleable or optimal for those kids? Now, just to take you through few examples of each of these things before we talk in more detail on clinical decision support, is like, for example, for diagnosing diabetes, not only people are using traditional markers like BMI, family background, the liver enzymes, the triglycerides, but there are also unconventional approaches. For example, in one study from China, they tried to predict the presence of diabetes based upon your facial features. And according to this paper, they were they were correct 99.02% of the time using one of those approaches. So we may not be far away from a point where somebody makes a profile on Facebook and Facebook starts showing him ads of artificial sweetener because Facebook knows that person has diabetes even before that person knows that he has a diabetes. Uh, Predicting complications, we already have diabetes now based upon what our clinical profile looks like and what are my chances of having some complication at later date. For example, in this study, just looking at ultrasound images, they could predict what the renal functions, what the blood renal functions of that person is going to look like, and what's going to be the course of those renal functions. And then one field where one field where one field where one field where AI has come of age and is already being used at patient level is detecting complications, specifically in case of retinopathy. Now, at least in Delhi, in metro cities in India, so people can go to labs and then they would do a fundus camera scanning, and then the algorithm, based upon the algorithm, the camera would tell itself on images itself that the software would tell us whether what are the chances of that person having retinopathy and whether a further ophthalmologist consultation is needed or not. Now, what we should be more aware of is clinical decision support system, because that's little difficult to make. We are at very early stages of our understanding in this field. Now, clinical decision support in type 1 and type 2 require different kind of artificial intelligence approaches. For example, in type 1 diabetes, although it's very labor intensive, it requires people to really be into managing type 1 diabetes. But if you look at the variables, namely the food, the carb intake in that food, the insulin carb ratio, the exercise, and the outcomes, which means the optimal glycemic control, they are all well defined, and then they are all connected with well-defined rules, almost well-defined rules. So the rules can evolve with time, but at any particular time, they are very well defined. So making an expert system for clinical decision support for type 1 diabetes system is a rule-based expert system can be a great starting point. For type 2 diabetes, because it's much more complex. One that your beta cell function decreases with time. So then if your weight goes up and down, then your insulin resistance can also change. If your behavioral factors, whether you are doing diet, you are adhering to medications, you are adhering to exercise or not, and then as a action point, there are multiple medications to be chosen from, and then there is no clear distinction as to which drug would be useful, specifically useful in which particular condition. So while we know what the inputs are, we know what the outcome we require is an optimal glycemic control, but we are not very sure about what the rules are which connect these inputs to outputs. So in these cases, the little higher version of machine learning, supervised machine learning as we call it, can be used, where we define what outcome should look like and what input variables would be, and then the machine is going to make its own rules to connect those inputs and outputs. Now, generally speaking, we don't believe that in type 2 diabetes expert system are going to be better, but it's not that people have not attempted it. In one of these papers from 2015, which was sponsored by Novo Nordisk, they chose 12 experts and they were given 930 clinical scenarios, and then they were asked as to what next diabetes drug are they going to use after metformin, and then as a third line OHA drug. And then you won't believe, but in 60% of these case scenario, there was no clear consensus between 12 experts on these things. So that's the limitation of making an expert system in type 2 diabetes, because everybody goes by their own experience. Second thing is that the behavioral factors were not ever considered in any of these expert system, because they are very difficult to define by way of rules per se. So now if we try and implement supervised machine learning or any machine learning technique, what we need to have is an access to a baseline data, which should be huge, which should be good enough, and which should be in a usable form, which should have all those inputs accounted for and all those output accounted for. And that's the reason that the papers or the studies attempting this are very, very limited. There are only 3 to 5 studies which are at present available in the published domain, and then even only 1 or 2 of them actually uses the large scale clinical data and then try to create a system from that data. Now, taking you through our own example, or taking you through your own ABC steps as to how can somebody think of making an artificial intelligence system for any problem that they have. And I'm going to give you an example of this clinical decision support in a while. So basically, if you want to make an artificial intelligence system, first of all, we need to define what our problem is. What is it that we want to do? For example, in this system, we want to devise a clinical decision support system, which, given a patient's particulars, should be able to identify what all OHAs that patient should be on. Now, we need to define data that is needed to solve a particular problem. Now, for example, in this case, that data would be what is the pre-existing prescription of that patient, what is the BMI of that patient, what is the current HbA1c of that patient, what are the behavioral factor of this patient looks like, whether he is adhering to diet and exercise or not, whether he has hypoglycemia or not, whether he has got contraindications to a particular drug or not. So you combine, so you need to have all those data already there in your data set. Then you pre-process and transform data, which means that the data should be in a usable form. For example, for behavioral factors, those behavioral factors should be in a Likert scale, in the sense that they should be clearly 1 to 5 a scale, so that the machine knows that there is a clear linear relation between the grading on which machine learning rules are to be devised. And then, for example, in India, we generally prescribe by brand name, so you have to transform that into the generic names of those drugs. So pre-process and then transform that data. Then you try to choose what machine learning algorithms would be appropriate for that data, and then you try 2, 3, 4 type of machine learning algorithms, and then try and see which algorithm fits your data best. And once you have some solution, then you test that solution on some subpart of the same data on which these entire rules are being devised. And then once those things are validated, then you go ahead and do a field study with a new clinical data, and then try and see whether this solution is actually useful or not. So that's exactly how we went about it. So at our clinic, we took a 5 years worth, 15,000 prescriptions for almost 5,000 patients. And then we did a preliminary analysis as to what all factors are affecting the optimal glycemic control in this patient population. So what we realized was that the patient's behavioral factor were the major drivers of optimal glycemic control, not the drugs that they were being given. So we decided to further prune this data to include only those data sets in which we had complete access to the patient behavioral factors, and that substantially reduced our data. So in current study, we only used around 1,700 prescriptions from 940 patients, and then we try to devise a system in which, as we talked, that we have a defined inputs in form of patient characters, and then we need to define as to what all OHS to be used in that particular patient based upon the characters, as we discussed on the previous slide. So we devised these rules on 2/3 of our data set, and then we left 1/3 of data set for the testing again and again, for validating that test results. So machine made its own rule. For example, to define whether sulfonylureas would be used in a particular patient in a particular situation. So the algorithm took into account whether it is there prescribed in the previous prescription, what the HbA1c, BMI, hypoglycemia incidence, fasting blood glucose looks like. And we devised these random forest algorithms for all the OHs that are being used in our practice. And then for predicting individual drug class use in a particular situation in a particular patient, our prediction was pretty accurate, more than 85%, with 85% being in DPP4 inhibitors. A complete drug prescription accuracy, which means that the prescription looks exactly like what it was actually prescribed, was in 72%. But it can, in clinical practice, it can actually be little bit more, because we know that there can always be situations in which you can equally use two drugs without any further compulsions. And just a bit word about type 1 diabetes. So there is great strides which are being made in analysis of CGMS data predicting hypoglycemias and hyperglycemias, closed loop insulin predicting insulin infusion rates based upon what actual patient's blood glucose data is great. But most of these specifically insulin pump solutions are not applicable to developing countries, to India, and to all of us in Southeast Asia. So what we need is solution on people who solution for people who are on multiple subcutaneous insulin injections. There are a lot of piecemeal solutions are available. We are also working on one of those comprehensive solutions specifically for people who are using MSI. But I think that's a story for another day. And just to summarize, AI in diabetes care is on cusp of revolution. And diagnosis and prediction are two areas that are going to see major progress in coming times. Management is difficult and would be hard to replace. AI is only as good as data, and uniform data collection by all of us involved in diabetes care is the need of the hour, and key to solving artificial intelligence. If we are able to implement it successfully, then AI can enhance breadth and depth of diabetes care beyond imagination of anybody. Thank you so much.